Hello again. So, welcome to the last video. Finally, the renal handling of calcium, phosphate, and actually magnesium. No? Bakit ko nag other electrolytes? Hindi ko alam. Magnesium lang naman yan. No? So, we're going to talk about these three, but more of these two, the calcium and phosphate. Si magnesium, two slides lang siguro siya. So, there's actually a relationship between calcium and phosphate. No? They are actually, again, Ateneo Lasal, RAAS and ANP, insulin and glucagon, something like that, no? Calcium and phosphate. Although both of them are very important for bones, but they have the relationship between these two is quite opposite, a little bit opposite, kumbaga, no? So calcium is important because it's for coagulation, for muscle contraction. Remember, diba? Muscle, we need muscle. Blood coagulation, Dr. Bartolome discussed, calcium, they thought that calcium is a factor for, necessary for the clotting factors. Okay, bone homeostasis, okay. I think this bone homeostasis will be discussed by sino ba? In the fifth long exam in the endocrine. But I think you already know that you need calcium for your bones, no? Nerve function and secondary messenger. And calcium is important for exocytosis of those neurotransmitter. Okay, so these are the factors. The plasma serum, some 45% are bound. More on that in the fifth long exam. Okay, Dr. Jacinto, I believe, will be the one who will discuss this. Okay, and phosphate, on the other hand, phosphate is important because ATP, adenosine triphosphate, cyclic AMP, 2,3-BPG. So phosphate is very important. Phosphate is also important for acid-base balance, which I think it will be discussed in the lecture in the acid-base. Phosphate is also important for inactivation and activation. Dephosphorylation, phosphorylation in your biochem, no? So very important siya, no? So yeah. So for calcium homeostasis, let's talk about calcium first, no? There are three areas for calcium homeostasis, or three organs that is very important in regulating your calcium: intestine, bone, and kidneys. But I think bone is the most important, no? Sa intestine, you absorb, no? I think this was tackled already, I hope, no? By you absorb calcium by vitamin D, no? You need vitamin D for calcium absorption, and calcium absorption happens in your duodenum. Bone, we will tackle that by in the fifth long exam. We're going to more focus on the kidneys. Okay, we're going to focus on kidneys. You will talk about calcium homeostasis again overall in the fifth long, because the parathyroid hormone, which is the primary regulator for your calcium, is discussed in that fifth long exam. Okay, if meron kang aldosterone for sodium and potassium, if meron kang insulin for glucose, di ba? Meron kang parathyroid hormone for calcium. Parathyroid hormone loves calcium. So parathyroid hormone secreted from the parathyroid gland, which is found in the thyroid gland itself, no? And this parathyroid hormone enhances calcium level in the blood. They love calcium, so they increase calcium level. Okay, ano lang yun? Introduction sa endocrine sa fifth long exam. So, parathyroid, love calcium. Okay, tandaan yon. Vitamin D loves calcium, kaya calcitriol siya. Okay. Calcitonin, on the other hand, doesn't like calcium. No? Calcitonin, ayaw ko sa'yo. Okay. Calcium, tonin. I don't know how, but tonin. Okay, ayaw ko, in short. So, in short, parathyroid and calcitonin, you will know this, okay, in the future. Let's talk about kidneys. Okay. So, again, around 60% of your calcium is actually filtered out in the glomerulus. So, filtered out. But 90% of them are reabsorbed in the proximal tubule and thick ascending limb. You can see 90% again of this calcium, diba? Si potassium, majority reabsorbed in the proximal tubule. Sodium, water, bicarbonate, majority of them are reabsorbed in proximal tubule, even calcium. But take a look at here, passively, paracellular. I go back again to my lecture in the proximal tubule and the thick ascending limb. They are reabsorbed passively by solute drag in the proximal tubule, in the thick ascending limb, via this lumen positive transepithelial voltage. Okay, I've talked about that. So go back again to that lecture. But in the distal tubule, take note, distal tubule, it is active because of your because of your parathyroid hormone, okay, transcellularly. So the parathyroid hormone will stimulate a channel that will be responsible for the calcium reabsorption. Let's name it calcium channel. Or in burn, they call it the TRPV5 over 6. Uh, that's too much. I will not ask that. Calcium channel, okay na sa akin. Pero ang gusto kong alamin nyo is that the active reabsorption of calcium happens in the distal tubule, and only 9% is actually active. The rest, the 90%, which is found in the proximal tubule and thick ascending limb, passively or paracellular. Okay? Tandaan nyo siya. So, yun. So, this is what PTH enhance. So, PTH will enhance this channel. So, there's more calcium will be reabsorbed, and calcium will bind to this calcium, this CB, your calbindin, okay? To keep your calcium low inside the cell so that more calcium will be reabsorbed. Kasi nga, higher to a lower concentration area, so para ma-reabsorb. Okay? And then reabsorb through this transcellular mechanism. Anyway, basta ma-reabsorb siya. Okay. So, yun. And then, yeah, so that's it. How about phosphate? No? How about phosphate? How do we regulate phosphate? Okay, so same thing. 3 organs. Kidneys. Okay, oops, I wasn't able to put bones, intestine, and kidney. So those three factors again. Those three factors again. But we're going to focus about kidneys. Okay, in the 5th long exam, we'll go back to this again. And then again, there's another regulator, the PTH again. But this time, PTH does not like phosphate. PTH enhances phosphate excretion. So in short, CPTH loves calcium but hates phosphate. That's why PTH, a mnemonic for that in USMLE is phosphate thrashing hormone. I don't like you, phosphate. Go out. Get away from me. That's why when you have increased PTH, calcium level goes up, phosphate goes down. Okay, calcium goes up, phosphate goes down. Okay, so yun yung function ni PTH. Calcitriol is a different scenario. Calcitriol, ano yan eh, two-timer. Calcitriol, vitamin D, loves calcium and phosphate. So calcitriol will reabsorb phosphate and calcium in the intestine. Okay, but more on that in the 5th long exam. We're going to focus on kidneys. So in kidneys, okay, again, majority of them are reabsorbed in the proximal tubule. 80%, as you can see, no, via sodium phosphate symporter. Pero PTH will inhibit the transporter. If earlier, PTH will enhance a calcium channel in the distal tubule to reabsorb, here PTH inhibit this symporter so that sodium will not be, so that phosphate will not be reabsorbed. Okay? So again, majority are reabsorbing PT. Nothing happens in the thick ascending limb. But take note, the phosphate exhibit transport maximum. Very small. That's why mabilis maubos or mabilis masaturate itong mga transporter, mabilis din makita ang phosphate sa urine. That's why you can expect 10% of phosphate in the urine. It's expected. Okay? It is expected. Nothing problem with that. Okay. Some are excreted to buffer some non-volatile acid. Okay, you'll know about that in acid base. But anyway, 10% are excreted somehow. Okay, 10% are excreted. Another 10% are actually reabsorbed in the distal tubule somehow. Okay, so I want to show you here. So this is from the burn and Levy. So you can see this true transporter. There's a true transporter, the NPT1, NPT2A, NPT2C, and there's even other NPT1 pa nga, no? I'm not particular with those NPT1, NPT2, basta importante sa akin, sodium phosphate transporter. Okay? So, they said NPT2 is the most important, which transport 3 or 2 sodium with 1 phosphate. But PTH inhibit this too. Okay? PTH will inhibit this too. Okay? So, yun. And that's why, whenever a patient with kidney problem, okay, go back again to application. Whenever a patient have kidney problem, PTH will not be able to attach, okay, PTH will not be able to activate the calcium channel and not able to inhibit this transporter. So somehow, what happens is that patient with kidney problem will have low level of calcium because they could not reabsorb some calcium in the kidney, okay, because of a PTH, because of kidney problem, insensitivity, no? At the same time, phosphate accumulates inside the body. So patient with kidney problem, you will notice that they have high potassium level, they have high phosphate level, but low calcium level, okay? And sometimes low sodium level then, no? But anyway, yun. That's too clinical na masyado, okay? So now let's, in terms of regulating, no, that's why I compare these two, calcium and phosphate, side by side, no? Pag-usapan natin silang dalawa side by side, no? So these are the factors that will regulate calcium and phosphate. So parathyroid hormone will increase calcium reabsorption but decrease phosphate reabsorption. Okay. By the way, be careful sa increase-decrease. Take note, parathyroid hormone will increase reabsorption of calcium but decrease calcium secretion. So be careful with the word reabsorption and secretion. Okay? Huwag kayong malito doon. Some book, probably you might read a book, oh doc, I thought sabi ni doc, PTH will increase calcium. Bakit dito? PTH will decrease calcium. But take note, PTH will decrease calcium secretion. So be careful ha. So yun. How about calcium, no? Calcium, high calcium will decrease calcium reabsorption. Basically, that's it. Because parang hyperkalemia, high level of potassium, excreted. High levels of sodium, excreted. High level of calcium, you also excrete it. Okay, you also excrete it. Okay, for phosphate, not much affected. But take a look at here, phosphate. Phosphate will also decrease reabsorption of phosphate kasi high levels of phosphate, excrete mo na si phosphate. Pero high levels of phosphate will also enhance calcium reabsorption. Why? Because high levels of phosphate will trigger your PTH. PTH will now, okay, PTH will now cause reabsorption of calcium. Okay? Dito sa calcium kasi, when you increase calcium, PTH will not be released. So if there's no PTH, then phosphate is not much affected. So calcitriol, we're talking about calcitriol, vitamin D3. So it will enhance, no, somehow. Pero ang majority of your action of your vitamin D is in the intestine actually, no? In the intestine. Okay? So not much of effect of calcitriol in the kidney somehow, no? So more of the intestine. Calcitonin. Calcitonin has more effect on the calcium. Okay, that's why high levels of calcium will release calcitonin, and calcitonin somehow weird, no, will also enhance calcium reabsorption. Pero what calcitonin do? It will do bone formation. No, it will cause calcium to be deposited in the bone somehow. Okay. FGF or fibroblast growth factor 23. So this is also like your PTH, it decreases your phosphate reabsorption. ECF volume. If I increase my ECF volume, what will happen? Both will be decreased reabsorption. Diba? Earlier, sabi ko, I increase my ECF volume, I enhance sodium excretion, I enhance potassium secretion, I enhance water secretion, I also enhance calcium and phosphate secretion, diba? By decreasing their reabsorption. Okay? For acidosis, okay? Acidosis said to be the H ion will inhibit the calcium channel, thus less calcium will be reabsorbed. Okay, less calcium will be reabsorbed. Also, the direct effect of acidosis also affect the phosphate reabsorption. So dahil acidotic siya, more H will be secreted, you also have to somehow excrete the phosphate to combine it with your H ion for the acid-base secretion, for it to become titratable acid. More of that in the acid-base, I think, no? So, yun. And then alkalosis, opposite effect lang siya. Okay. Okay, so you have to know the difference between calcium and phosphate, no? They are, to study them, you have to study them side by side. Okay. And lastly, magnesium, no? Magnesium. It's an important cofactor. Magnesium is important, I believe, in biochem, no? When we talk about the kinase, no? The phosphofructokinase, the other kinases, no? Whenever you have, I think kinase, no, you use magnesium because magnesium is important for ATP, no, for production of ATP. Without magnesium, there will be no ATP production. So that's why I'm talking about biochem, okay? So, yeah. And how do we handle magnesium? Very unusual because magnesium is the only electrolyte that is majority of them are reabsorbed in the thick ascending limb. In the thick ascending limb. Take a look at here. 15% are only reabsorbed in the proximal tubule. Okay, in the proximal tubule. 70% are reabsorbed in the thick ascending limb. Diba? Sodium, water, bicarbonate, glucose, amino acid, potassium, phosphorus, calcium, name it, all of them are reabsorbed in the PT, or majority of them are reabsorbed in PT, except magnesium. Magnesium is reabsorbed, majority of them, in the thick ascending limb. In the proximal tubule, they are reabsorbed via solvent drag. Here, through a paracellular mechanism. Okay? So, the site of regulation will be on thick ascending limb kasi nandiyan yung major site of reabsorption and distal tubule. And again, the regulation will depend on the magnesium level. High levels of magnesium will happen, decreased reabsorption kasi masyadong mataas na, or increased magnesium secretion. High level of ECF will also enhance magnesium secretion. Okay? Calcium level increase will also decrease your reabsorption or enhance excretion. And hydrogen ion also. Acidosis, same thing, no? Medyo same din siya sa phosphate and your calcium. Okay? So, sometimes we don't study them one by one. We study them as a whole. Increased ECF volume will enhance secretion of all of them. H ion increase will also enhance secretion, all of them. Okay? Or decrease reabsorption. Okay? Except for phosphate, I think except for potassium. So this picture from boron shows us the magnesium here, okay? Ata si magnesium, okay? Through a channel called paraselene, but I'm not going to much talk about that. What I want like to emphasize here is magnesium is reabsorbed through a paracellular mechanism, like calcium, like potassium, and even sodium in the thick ascending tubule. Again, go back to my lecture in the tubules, okay? So, with that, we end our renal physiology 1 and 2. So, if you have question, put it in, message me in the discussion board. I highly encourage you to message me in the discussion board so that other students can see your question, okay? So that mag-learn din sila from your question. Suggestion in the future, maybe you can help me to improve more. Okay, I will give a feedback form and help me to improve in my lecture. Of course, like in my PowerPoint setup, of course in my grammar, my speed. Am I talking too fast or not? Help me with that. Is it info overload? I'm sorry with that, but I already cut down a lot of information already, no? And then again, this is my email if you have some clarification. And I hope you can understand this meme, no? Bakit number 1 si urine, number 2 si intestine, no? Kasi mas ma-interesting ang renal physiology. No? Kidding aside, diba? Pag sinabi nilang magda-number 1 lang ako, no? When you say magda-number 1 lang ako, iihi ako. Magda-number 2 ako, magpupoops ako. Something like that. And I would like to end my video with this verse, no? Especially New Year, with a lot of happenings in 2020, 2021. I hope, we pray that this will be a new something, a new year, a new output, or a new lesson that we'll take. So this verse, Psalms 90 verse 12, is one of my favorite verse. Teach us to number our days aright, that we may gain a heart of wisdom. When we know that our days are limited, okay, we will gain a heart of wisdom, a wisdom that will appreciate our life, appreciate our day-to-day life, every minute of our life. And with that, we will walk as if that we are trying to please God and trying to be more compassionate with other people. Okay. With that, these are my references. And Vernon Levy will be probably the top most reference. Vanders is a good also, and Guyton and Hall. And but my lecture is enough. Um, Lecturia is also good, but this reference is enough also. So with that, thank you very much for listening and see you on the synchronous class. Thank you.